Dear colleagues, welcome to the ISIAT webinar of 2026. This is the first appointment. I'm very proud to share again with you some very important topics about the intra-articular treatment. And in this occasion, we have a topic that is very relevant, and we put to ourselves the question, what does hyaluronic acid encounter once injected? What happens when the hyaluronic acid is injected inside the joint? And so we have two speeches. The first is made by Professor Ali Mobasheri, very outstanding speaker from the University of Oulu in Finland, and he will speak about the microenvironment inside the joint and which determinants are relevant for the clinical response to the hyaluronic acid injection. Then we have another very important friend of ISIAT and outstanding professor, the Professor Xavier Chevalier from Paris, France, and he will speak about the immunological and molecular interaction of intra-articular hyaluronic acid injected inside the joint, what this product is able to interact with the cytokines, with the cells, and with the tissue. So this are two important speeches to better understand, to go deep in the mechanism of action, and the opportunity of hyaluronic acid, and also to understand the effect of hyaluronic acid. And at the end, after these two presentations, we will have a common discussion. So that it's a pleasure for me to give the floor to the Professor Mobasheri for the first speech.
Hello, dear colleagues, ladies and gentlemen. I am delighted to be invited by Professor Alberto Migliore and ISIAT Events to deliver this webinar during the first ISIAT webinar event of this year in 2026, in the same session as my friend and colleague, Professor Xavier Chevalier from Paris. This is the title that I was given, the intra-articular microenvironment as a determinant of clinical responses in hyaluronic acid treatment. These are my disclosures, including companies with whom I have had a relationship in terms of consulting and lecture fees. I have my own consulting company in the UK, and I'm a shareholder of 𝗜𝗡𝗧𝗏 Therapeutics. And my research is funded by the Research Councils of Finland and Lithuania, as well as the European Commission. And of course, during my presentation, I will discuss a number of hyaluronic acid formulations, but I won't specifically endorse any product. Osteoarthritis is the most common form of arthritis globally, affecting more than 500 million people at this point in time, with an estimate of affecting 1.2 billion people by 2050. And this is a major global burden on healthcare systems and the patients. The lack of effective treatments represent a very significant unmet medical need. And if you look at the burden of osteoarthritis, it's approximately 11% of the total global burden of disease. This illustration highlights the concept of osteoarthritis as an iceberg, where what is above the waterline is visible in terms of the illness on the left-hand side, the symptomatic aspects of the disease, and the imaging features, radiographic features, and MRI on the right-hand side. But of course, the opportunity for us is to go deeper below the waterline and look at the larger chunk of the iceberg, which is in the water, to look at undiagnosed pre-symptomatic disease and use biomarkers to look at early events in osteoarthritis development. and be able to study the serial micro and macro injuries that are thought to contribute to the progression of the disease. This is from a nice paper published in Osteoarthritis and Cartilage in 2024 by Martijn van den Bosch and colleagues in the Netherlands, highlighting what we used to think about osteoarthritis in the past and what we think of osteoarthritis now. We used to think of it as a wear and tear disease, which is only as a consequence of age and injury, and the main tissue that we studied is cartilage. Now we think much more broadly about all the tissues involved in the synovial joint, cartilage, subchondral bone, meniscus, Hoffa's fat pad, synovium. There's enormous interest in modulating synovial biology, as well as muscles and periarticular ligaments. And we don't think of osteoarthritis as a wear and tear disease anymore. We think about the risk factors, we discuss endotypes and endophenotypes, and in previous years, during the ISIAT webinars and the annual conference, I've talked extensively about the emerging concepts of clinical phenotypes and molecular endotypes and how we might be able to take a more precision-based approach to the treatment of osteoarthritis with intra-articular injections such as HA. This is from a recent paper we published earlier this year. It highlights the importance of these two concepts, mechanoflammation and metaflammation. Mechanoflammation involves mechanical stress, activation of mechanoreceptors, and then molecular signaling through integrins and DAMPs, and consequently activation of innate immunity. Metaflammation involves low-grade inflammation with this poly combination of pro-inflammatory adipokines and cytokines, also contributing to innate immunity activation, activating a number of catabolic and inflammatory pathways further downstream, and consequently there's joint damage, effusion, synovitis, and further catabolic destruction and fibrosis in the joint. Now, it's very important to catch the disease as early as possible, and this is a concept we introduced in 2021. The so-called window of opportunity is pre-symptomatic or early symptomatic phase of the disease, which allows us to step in and make a real difference to the trajectory and long-term outcomes of the disease. And we propose in this paper that people with early-stage knee osteoarthritis typically present in healthcare with intermittent activity-induced pain, and this stage could serve as the so-called window of opportunity to address the disease in a much more manageable way. This is a paper from SKO talking about novel approaches to the stratified management of osteoarthritis, where we start to think about trajectories of people progressing slowly and more speedily in terms of disease progression, and thinking about using tools to stratify patients, not only for treatment, but also for better and more enhanced clinical trials of the future. And in this concept, you have early therapy, making difference to the patients, impacting the trajectory of disease, slowing it down. Late therapy, of course, having a less impactful influence on disease progression and potentially with more negative outcomes further down the line. But if you think about the current osteoarthritis treatment paradigm, the majority of patients who actually need support and treatment are between grades 2 and 3. This is the unmet treatment gap, the unmet medical need. What do we have in the early stages of the disease? We have non-pharmacological therapies, we have education, as well as non-steroidal anti-inflammatory drugs. We have corticosteroid injections, hyaluronic acid, and a number of slow-acting nutrient-based cystidoas. And of course, in the later stages of the disease, when joint destruction has progressed beyond this point of no return, we are looking at bone-on-bone scenarios, and then we have joint arthroplasty. But I think it's really important to think about the health economics. We have a lot of interesting developments in osteoarthritis. There's gene therapy, there's cell therapies that are being investigated, several are already in phase 2 clinical trials. But of course, the cost of these things need to be considered. And you need to do a very careful health economic assessment of the cost. And this is again where intra-articular injections such as hyaluronic acid come out very favorably, not just because of efficacy and safety, but also because of health economics. But if you want to be really critical of the field, you can look at the last 75 years and wonder why and how we've made so little progress since the introduction of acetaminophen in the 1950s, and then introduction of ibuprofen and naproxen in the 70s, and then the coccyps in the late 80s and 90s. In more recent years, we've only had approval of triamcinolone emulsion Zilretta by the FDA. And then on the right-hand side, where you have injectable HAs, we know these products very well. And so there needs to be more innovation in this area because of the unmet medical need. Then, of course, there's phenotypes and endotypes. I've only been allocated 20 minutes, so I can't discuss these in detail. But we need to consider the clinical phenotype and the molecular drivers of the disease in distinct subsets of patients before we treat them. And I think this is opening up new opportunities and windows for therapeutic efficacious targeting. And the concept of molecular endotypes is now becoming really widely investigated in terms of matching an endotype to a therapeutic asset, whether it's anti-inflammatory, pro-anabolic, or mediates some aspects of immune cell function in the joint and alters the microenvironment, which we are talking about in this lecture. This is also a very nice review from Ian Jones and colleagues published in 2019 in Nature Reviews Rheumatology, talking about intra-articular treatment options for knee osteoarthritis. I particularly like the figure in this paper looking at drugs divided into biologics and small molecules, all the different classes of drugs that are being investigated. Then, of course, we have HA as a medical device and the concept of HA plus excipients plus additional chemicals as drug-device combinations. But we need to consider the really important fact that the intra-articular microenvironment of the joint changes with age and with the disease progression. And the microenvironment actually dictates the success of any kind of intra-articular injection, such as HA, because it can determine how long the HA can last in the synovial space. It can determine how HA interacts with the extracellular matrix and with catabolic enzymes within that environment, and of course with the cell and the receptors on the cell. Then eventually there's metabolic clearance. And of course, if you think about it very deeply, joint inflammation, oxidative stress, matrix breakdown products, and synovial-derived factors, those factors that are produced by synovial fibroblasts and macrophages in the synovium also can influence the biology and the efficacy of hyaluronic acid. So we think about this inflammatory vicious cycle, and we think about this as an inflammatory process where all of the molecules that have been identified as inflammatory and catabolic participate. Cytokines were mentioned, DAMPs and toll-like receptor ligands were mentioned. And this is very nicely summarized in the third chapter of Kelly and Firestein's textbook of rheumatology with my colleagues Mary Goldring and Richard Loza. We've highlighted all the key pathways, the cellular mediators and periarticular structures that are involved in this process. But there's a very nice year in review lecture from these colleagues published in Osteoarthritis and Cartilage, looking at the involvement of factors in synovial fluid, more detailed evaluation of what's happening in the synovium, which molecules are involved, and which cell types they interact with. So a really complex process. And then, of course, the enzymes that are involved, the matrix metalloproteases, the cathepsins, the hyaluronidase, ADAMTS4, ADAMTS5, and the molecular interactions with the matrix components within the joint. But we need to take a step back now and really think about how molecules get into and out of the joint. This is the example of a soluble drug injected into the joint. A soluble drug is rapidly cleared. And of course, HA is not a soluble small molecule, it's a larger molecule, but we also need to consider how long HA can persist in the joint, because it has a time-dependent residence within the joint. And the local and systemic interactions of the synovial fluid also need to be considered. The communication between synovial fluid and the synovium itself, the interaction between synovial fluid and articular cartilage, and other joint tissues such as infra-patellar fat pad, about which we have learned so much in recent years. And this is also a major contributor to that inflammatory and potentially resolving microenvironment in the joint. Please refer to this very nice recent paper by Peters et al. And then, of course, the fat pad is where interesting biology happens. The fat pad is where there is communication between the crown-like structures formed by the macrophages, as well as the fibroblasts and adipocytes. And this environment also gets altered and changes with the progression of the disease. And that is also contributing to production of more inflammatory mediators. So we need to think beyond just synovial fluid. We need to think beyond just the synovial lining. There's also contribution of the infrapatellar fat pad. So the microenvironment can influence clinical response, and understanding the microenvironment can potentially explain why patients respond to HA differently. Obviously, I'm not going to get into the concept of viscosupplementation and the interaction that high molecular weight, for example, HA has in terms of lubrication and viscosupplementation. But we need to think about the inflammatory and oxidative stress aspects. The microenvironment of the inflamed osteoarthritic joint is rich in many reactive oxygen species and catabolic enzymes. I've mentioned MMPs and aggrecanase. I've also mentioned hyaluronidase. Hyaluronidase has a direct impact on HA residence and how long it can last in the joint. So these elements can cause rapid degradation of injected HA or indeed any other biological peptide-based or protein-based intra-articular injection, reducing the half-life of what is being injected into the joint. But of course, HA has anti-inflammatory properties that are well established through in vitro studies and has the ability to interact with CD44 on the cell membrane, TLR4 and ICAM1, and in a very heavily inflamed microenvironment, it's predicted that high molecular weight HA can suppress the inflammation effectively. So I'll mention interleukin-1 beta very briefly. Interleukin-1 beta and its interaction with its target receptor, IL-1 receptor, is an important signaling catabolic and inflammatory pathway. It's being targeted by gene therapy, but also this pathway is a target of hyaluronic acid. So when we think about the microenvironmental change in the joint as the disease progresses, clinical outcomes are strongly tied to individual patient profile. And I think we need to think about the progression of the disease. Patients who have very advanced disease are probably less likely to respond to any kind of intra-articular injection. This is where some patients may become unresponsive. Patients with less severe structural damage could have more robust therapeutic outcomes. And of course, we are learning so much more about the impact of obesity on the disease. And we now recognize that lower body mass index is tied to better outcomes, high BMI, high adiposity, and BMIs over 30 and 35. Morbid obesity can have really negative impacts on any kind of intra-articular injection. So we need to think about the individual level risk factors and the joint specific risk factors in this context. I want to highlight the expert consensus on hyaluronic acid injections for knee osteoarthritis, a patient-centered approach. This paper was published a few weeks ago as a product of an SKO working group. First author, Nicholas Fuggle. Many colleagues are involved in this paper, including Professor Migliore, our colleague and ISIAT chair. And I was delighted to be the senior author along with Professor 𝗜𝗕𝗓𝗓 and Professor 𝗜𝗓𝗓𝗓𝗓𝗓. And the key points from this paper are as follows. HA is naturally occurring and widely used for the treatment of osteoarthritis. The majority of the published literature strongly supports the use of HA because of its very impressive safety profile. Indeed, there's nothing safer to inject into the joint than the term in terms of adverse effects. There are a number of recent papers that have grossly over-amplified a very small number of adverse effects. It's very safe. And intra-articular HA can be injected in combination with other agents. For example, sorbitol, mannitol, chondroitin sulfate, tranexamic acid, and of course, the emerging treatments include polynucleotides. And there's high molecular weight and low molecular weight HA. But I also want to highlight the fact that osteoarthritis isn't just about intra-articular injections. It's about education, it's about promoting physical activity, weight management, and it should be managed by a multimodal approach using a multidisciplinary framework, and this is extremely important. Prioritizing the patient perspective is also very important in terms of shared decision-making. Treatment plans for patients should be very empathic with good communication between the patient and the healthcare provider. We know that for doctors who really care about their patients empathically and actively listen and align their clinical goals with the patient expectations, always have, in real-world studies, much better outcomes. Safety is always the most important priority. And of course, patients prefer, as we hear more and more from them in terms of their preferences, they prefer single injection formulations over many consecutive injections. And there's also a higher rate of fallouts from repeated injections in clinical trials that involve many visits to the clinics. So in terms of making an informed choice, clinicians should provide clear stepwise education on the different formulation, discuss the molecular weight, additional components without causing any cognitive overload for the patients. And when we think about the impact of the microenvironment of the joint, that shouldn't be discussed with the patient. That's probably too scientific. So in conclusion, the key clinical takeaway is that intra-articular microenvironment will dictate how the joint responds to therapeutics such as hyaluronic acid. We know that HA actively restores joint homeostasis, limits inflammation, and inhibits catabolic activity, but its longevity and its impact in the joint depends on the inflammatory and catabolic microenvironment and the state of progression of the disease. I'd like to acknowledge all the international societies that actively care about this area, particularly SKO in this context. I'd like to thank ISIAT for the opportunity to give this webinar and Professor Migliore for his support. We have a couple of EU projects. This is a cell therapy intervention for osteoarthritis currently under investigation, the Proto project. And we also have the Encanto project led by Ivan Martin and colleagues in Basel. And finally, this is a public-private partnership that was launched in January this year, which aims to develop a surrogate clinical endpoint for osteoarthritis clinical trials. This is where I live and work in Finland. You're very welcome to visit me. Thank you for the opportunity to join you, and looking forward to seeing you face to face in 2027. Thank you.
Thank you, Professor Mobasheri. Thank you, my dear friend Ali, for this lecture. you cover a lot of topics, and it is a very complete overview about the osteoarthritis and the role of hyaluronic acid and the clinical and determinants for the response of hyaluronic acid, and also the explanation of the mechanism by which this determinant can influence the response. And we will have the comment and the discussion at the end. So it's a pleasure for me to give the floor to another friend, that is our colleague Xavier Chevalier, Professor Chevalier, in order to have the second lecture. Please, Xavier.
Dear colleagues, it's a real pleasure for me to participate to this webinar on hyaluronic acid. And first of all, I would like to thank ISIAT for this webinar, but also my friend, Professor Alberto Migliore as well, and my co-lecturer, Professor Ali Mobasheri. So we're going to speak a very interesting topics on the immunological and molecular interaction of intra-articular HA. This is my conflict of interest. Well, just to start, we always are facing the same paradox with HA, because we have mechanical properties, springs effect and viscous oil effect, but this cannot explain the long analgesic effect, because the resident time of HA after intra-articular injection is, as you know, very short, at least some hours, or about 10 or 15 hours. So there is a paradox in the mechanism of action of HA. And to understand how it works, we should come back to the link between HA and its own receptors. It is very important to understand that if HA links to the CD44 receptor, it can induce more tissue repair, cell and matrix remodeling. But if HA links to TLR4 or to TLR2, it can induce inflammation, cell differentiation. And if HA link to LIFE1, it can induce survival of the cells and angiogenesis. So this is a very key point to understand that the link between HA and receptor is clearly influencing the response of HA. So beyond the mechanical properties of HA, we can divide the action in 4 groups. One is on a chondroprotective effect, one is on anti-inflammatory effect, one is more pulsing on the subchondral bone in a way, and one is very important, is to try to understand the analgesic effect of HA. But to start and to try to understand why there is a so long effect of HA, we should start with the own effect with the autocrine production of HA. If you add HA with molecular weight of over 500 kilodalton, you can induce an autocrine production of HA. This is true in vitro with synovial fibroblasts, but this is also demonstrated in vivo in human trials. And you can see that in this a little bit old publication that if you inject free IL-GF20, you can induce an increased concentration of HA in the synovial fluid. So we have the proof that external HA can increase the concentration of internal HA. So let's start with the chondroprotective effect. And I tried to summarize in this cartoon several works. The result net effect is that it can increase the production of anabolic factor in one end, but decrease the production of catabolic molecule in the other end on articular chondrocyte. So the net effect is beneficial for the chondrocyte and the extracellular matrix. And just to illustrate my comment, you can see here that on articular cartilage, the production of nitric oxide is decreased with HA, and is also decreased when the articular chondrocytes are stimulated by TNF-alpha by IL-1. So just to illustrate this point, this is also true in vivo preclinical model. This is an in vivo preclinical model in rats with section of the meniscectomy. And you can see here that without HA, the extent of cartilage damage is quite important and is really decreased if the injection starts after the destabilization of the joint. So we have the proof in vitro, we have the proof in vivo, but also in vivo, one extremely important point is on the cell viability. It is proof, this is shown, that HA can decrease the number of articular dead cell, apoptotic cell, in a rabbit model of ACL. But probably the most interesting work is on the increased expression of major clock gene after intra-articular injection of HA. This is shown here on this slide. It suggests that in some part, the intra-articular injection of HA can restore the good rhythm of circadian rhythm and the chronobiology of the cells. Well, what kind of proof do we have in human? This is a human trial, very simple, free injection of HA, and we just regarded of the product degradation of collagen type 2. And if you look to collagen type 1 or collagen type 2-1 nitrosylate, you can see that you have a decrease, a small decrease, but a decrease in the degradation of collagen type 2, meaning that even in trial in human, we can demonstrate an in vivo effect of HA. So the second group effect is an anti-inflammatory effect of HA. And I try to summarize this in this one slide. If we take macrophages, or if you take articular chondrocytes, in both models, the addition of HA, which is bound to CD44, can not only decrease the production of free radicals, pro-inflammatory cytokine, but also, and maybe this is the most important point, it can prevent the action of pro-inflammatory cytokine, especially the IL-1 and TNF. So this anti-inflammatory effect is very strong and demonstrated in vitro. And just to illustrate my talk, a recent work, this is very interesting because it compares in a model of co-culture inflamed macrophage. Macrophage had been activated by stimulation by LPS, and in the other side, articular chondrocytes have been activated in presence of IL-1. And if you mix these two cell culture, but you add hyaluronic acid, you can strongly decrease the production of enzyme in articular chondrocyte, increase the production of collagen type 2. And this effect this is here in the green part, this effect go by the inhibition of the ERK intracellular machinery. And if we take now macrophage, which all know is a main player in the OA, especially in the early stage, in presence of HA, you can decrease the expression and the action of NF-kappa B. So taking together, this shows that HA has a strong anti-inflammatory effect, especially on macrophage M1. But we should keep in mind that there is a dark side of effect of HA. If you degrade the native molecule of HA, resulting in very small molecular weight HA or oligosaccharide, you have a paradoxical effect which can induce a strong inflammation. And the reason why is because this very small molecular weight HA can bind not to the CD44, but can bind to TLR family of receptor. And this link induces the expression of NF-kappa B, but also the MAPK kinase, inducing the production and expression of several enzymes, aggrecanase, gelatinase, MMPs, but also pro-inflammatory cytokine. So there is a paradoxical effect, but probably this is shown here on this slide on dendritic cells, comparing the action of LPS to small, very small HA, and you can see that more or less the pro-inflammatory effect of this small degraded HA is very important. But this is what is very remarkable, is that the negative action of HA, of this very small oligosaccharide of HA, can be prevented by the addition of the native molecule. If you add high molecular weight HA together with low molecular weight HA, the link of the high molecular weight to CD44 prevents the link of small oligosaccharide to TLR4, meaning that it can decrease the expression of enzyme, and in this work, it decreases the expression of MMP3. So, in other words, we can understand that the own production of a good and native molecule of HA can prevent the action of degraded HA, which can be observed in OA. So one most important point is to try to understand the analgesics, the long-term pain relief that we can observe after intra-articular injection of HA. And just to remind you that in a long-term disease, painful disease like OA, you all know that there is a peripheral but also a central sensitization of pain, meaning that if you have a non-painful normal stimulus in a patient with a painful OA, it can feel a normal stimulus as painful. Well, how can we explain this very fascinating analgesic effect? There is different potential and putative mechanisms of action. I try to list all three of them. The first one is a decreased production of pro-inflammatory cytokine. If you decrease the production of TNF, IL-1, and so on, you thereby decrease the sensitization of peripheral pain nociceptor, pain receptor. But it has been also shown in one work that you can also decrease the level of circulating NGF, which is, as you know, one of the main actors in the pain transmission. But in my opinion, the most fascinating action is probably what is being called the cage effect of HA. There is, because HA linked to several CD44 on the surface of the cell, it can have a protective effect putting over the nerve ending. And maybe this is one way to explain the analgesic effect of HA. It has been proved in vivo in this guinea pig model of OA by partial medial meniscectomy. And if you isolate the nerve ending and record the nerve impulse here in dark are really decreased after intra-articular injection of HA. Well, just to finish, the effect of subchondral bone are really mixed results with some positive and some negative results. But we should keep in mind, and I will show you that HA can penetrate in the subchondral bone of OA joint. Well, just to illustrate my comment, here on IL-1, on mouse calvariae, you can have an anti-inflammatory effect if you are in presence of hyaluronic acid. But one of probably the most fascinating work, which is quite an old work by a Japanese team, which shows that the penetration of hyaluronan, fluorescent hyaluronan, can be demonstrated here in the white arrow into the subchondral bone through the cartilage cleft. And if you recuperate after injection of HA, this cartilage explant and regard the production of MMP13 and IL-6, you can see that in presence both in cartilage, but also in subcutaneous bone, that in presence of HA, you have a strong anti-inflammatory effect on the subchondral bone. Well, there is more anecdotal effect on FGF, which is known, as you know, as regarded as a pro-inflammatory, but also pro-catabolic growth factor, notably in the deep layer of the degraded cartilage. Well, just to finish, this is a very important point. Could the molecular weight and the sources of HA influence its own molecular effect? And I tried to summarize in this slide the difference between high and low molecular weight. It is, in other words, compare linear, very small nodules to compact or very compact nodules if we are regard reticulated cross-linking HA. Well, the work show that high molecular weight, both in vivo and maybe probably in vitro, and probably in vivo, have a stronger chondroprotective effect. But in other hand, we do know that the linear HA link more easily to the CD44. So what kind of proof do we have? And I show you this work showing that in human articular cartilage, the chondrocyte viability is increased in presence of HA, and is more strongly observed in presence of high molecular weight compared to low molecular weight, especially if we regard the production of collagen type 2-1, of chondroitin, and of the growth factor involved in the anabolic response, which is HIF1 alpha. So how we conclude? We can conclude that beyond the mechanical property on viscosity, on the coefficient of friction of HA, there is a non-mechanical property of HA were based on the immunologic and molecular effect of this molecule. We can try or better understand the potential DMOA effect of OA, and that also the potential of long-lasting analgesic effect of OA. And thanks for your attention.
Thank you very much, Xavier, for this excellent lecture. Also, you cover a lot of topics, speaking about the effect and explaining the effect of hyaluronic acid, about anti-inflammatory properties, analgesic properties, and also the modulation of the chondroprotection, and also about the effect of some chondral bone. So I think it is very interesting for a lot of questions. So we can open both lectures for the question from the audience. I can check now if there are some questions. Okay. There is a question about teratype for Ali Mobasheri. Ali, you mentioned teratype in one of your slides, the phenotype, endotype, and teratype. Do you think that maybe the possibility to define in the future some kind of teratype responding better to hyaluronic acid?
Thank you for a really important and relevant question. I think it's important to consider that the word teratype is from the field of cystic fibrosis research. It emerged out of all the work that was focused on developing therapeutic gene therapy targets for cystic fibrosis. And gradually, the word teratype has gone beyond cystic fibrosis into many other disciplines of medicine, asthma, osteoarthritis, cardiovascular research. So first of all, bear in mind, it's not a terminology that comes from osteoarthritis or joint research, but it's possible to conceive an idea where if you have a much more inflammatory driven, synovitis driven osteoarthritis, let's call that a inflammatory phenotype that could be driven by an inflammatory series of endotypes, perhaps a single endotype, perhaps some overlapping endotypes, and that would constitute a potential theratype, a therapeutic subtype that could be targeted by an intra-articular injection. And interleukin-1 gene therapy could be one solution. And of course, leading up to that, HA remains a very solid treatment. But I think also weight loss, metabolism, these are other really important areas that are touching osteoarthritis. That could be viewed as a different theratype as well. Keep looking at the literature. Remember that terminology doesn't come from us in OA research, and I think there will be further progress in this area soon.
Thank you, Ali. There's another question that I think that is for both of you, because both of you have spoken about the inflammation, the activity on macrophages, and it is about the question is if hyaluronic acid has some properties, some effect on resolution, on resolving, about the production of resolving cytokines, and to switch the macrophages population from M1 to M2. There is some evidence or data about this?
I'd like to refer this message to my dear friend Xavier, please.
Well, what we know is that HA can counteract the M1 macrophages. I'm not really aware of work showing that it can translate M1 to M2, but we do know also that there is some other molecule that can do that. But it's a very relevant question because the player of macrophages is growing up, especially in the early phase of the disease. So I think that all action that could focus on this activating macrophage, especially in the early phase of the disease, is extremely important.
Fully agree.
Thank you. And also, there is another question that usually we speak about hyaluronic acid, but we consider this like a class. But both of you have correctly specified the differences of properties between the different products. Could you give to the audience some better or consideration about the differences between high molecular weight and low molecular weight, and especially to give some suggestion or information about the clinical use, how to differentiate this?
Over to Xavier again, please.
Okay. I think it's quite very important to discriminate because what we have in vivo and in vitro in terms of molecular weight of HA, and what do we have in clinical practice and in human trials. What we know, I've tried to summarize in these last slides, that high molecular weight seems to have more chondroprotective effect. So that's the first point. The second point, that the more the HA is longer, the more it is reticulated, the longer it stays into the joint. This is already proof and can explain that it might be a little bit superior in terms of clinical effect. And if we carefully look to the difference in clinical practice, it seems that it's not proved everywhere in the study which compare high to low molecular weights, that the magnitude, but most of the duration of action seems to be a little bit longer with high molecular weights and high molecular weight reticulated HA. So in other words, the more the HA stay, the duration, the residence time is increased, seems to be a little bit correlated with the duration of action.
Thank you. Thank you. This is important. And we can see if there are other questions. Yes, for instance. There is a question that colleagues would like to know something more about the effect of hyaluronic acid on subchondral bone.
Oh, it's a bit difficult to answer because I try to review the effect, and the effects are really mixed. There is some negative effect, I mean, or at least no effect, and there is also a positive result. I show you one positive result on mouse calvaria showing that it can prevent the action of IL-1. But to be honest, in vitro, the effects are a little bit more piercing that compared to the action of on chondrocyte. Just to come back to my presentation, I think there is a very, very nice work, the work from the Japanese, because it demonstrates that the intra-articular injection of HA could, in a damaged cartilage, penetrate into the subchondral bone. So it's important to correlate what we can have in vitro on the direct action of HA and what we can imagine to have in vivo, because in vivo, HA should target the cells of the bone, osteoclast and osteoblast. And this work demonstrates that it can target the deep layer of the cartilage as well as the immediate layers of the subchondral bone. But again, in vitro, the results are really pleasing with HA.
Thank you. I think that this can also introduce another observation, that is the window of opportunity that show Ali at the beginning. And if I ask you, which is the window of opportunity, or which is the stage of the disease where hyaluronic acid can have the best effect in terms of symptoms relief, but also also about the management of the disease, the stop the alteration of the disease. So would in your opinion, which is the area of arthritis, the intermediate of arthritis, which is the stage of the disease where hyaluronic acid we can put as indication, as a better indication, and can exert the best opportunity?
Ali?
Thank you, Alberto. I think having attended EULAR just a few days ago in London, we know that the term window of opportunity comes from other rheumatic diseases, and we're a little bit late in terms of thinking about this in a way, but it is important to recognize that osteoarthritis, early osteoarthritis, catching it early, treating it early, as it in many other diseases, will have an impact undoubtedly on the trajectory of disease progression and potentially time to surgical outcomes, time to knee arthroplasty. I think the earlier we catch any disease, and in this case OA, the better. We just need to sharpen those tools for early disease diagnosis and be able to treat OA earlier. So I would say in our limited arsenal, in the absence of disease-modifying agents right now, I think HA is a tool that we must utilize more broadly and more strategically. And if we can apply it earlier, potentially it could be a joint saver. It could change the trajectory of the disease progression.
Thank you.
Well, may I add a small comment, Alberto?
Yes.
I completely agree with Ali. This term of window of opportunity directly comes from rheumatic inflammatory disease. But in a way, as you know, when the disease starts, when the disease becomes symptomatic, it's probably too late. I mean, the disease is already very advanced. But anyway, saying that, we know that the effect of HA in all trials, the prognostic factor of HA, is working much better when you take Kellgren 1, 2 compared to late stage disease. This is purely factual, but it should interrogate us why HA is working better in very early symptomatic disease than after. And probably, I mean, maybe we can hypothesize that maybe the number of CD44 on the cell are changing. Maybe the unfriendly, very inflammatory environment in late-stage disease could more degrade HA and so on and so on. But the fact is that HA is much better working in early radiologic stage than in late radiologic stage. So in my opinion, we should prefer HA in a non-very symptomatic disease, in more early disease, and probably in disease not with a real pro-inflammatory phenotype, clinical phenotype, but maybe some days inflammatory endophenotype.
Thank you. And I think we have no more questions. And so first of all, I would like to thank the speakers for the lectures and also the audience for the interaction with the question. And also I would like to thank IBSA for giving us the sponsor for this webinar. And just as concluding remark, I would like to outline what is the proposal of a scale that the treatment of osteoarthritis is multimodal, multidisciplinary approach, multi-component. And in this view, I think that we can use hyaluronic acid treatment according to this very important information that Professor Chevalier gave us today, because this is a very important explanation of the mechanism of action, of what we know and what we also have to discover in the agenda of the research. But it's very important to understand that treatment with supplementation is an effective treatment, but a tool that we have to use together with all the other tools and all instruments that we have for a multimodal approach. So thank you so much for the support, and I would like to thank also the audience. And my last is to invite you for the next webinar that will be held on September, and precisely 22 of September. And the topic of the next will be refractory osteoarthritis, and we speak about how osteoarthritis can become refractory, and also about difficult to treat knee osteoarthritis. And our speakers in September will be Professor Glickowski from Poland and Dr. Tarantino from Italy. So save the date, and thank you again for your kind attention. Bye-bye.
Thank you. Bye.
Thank you. Bye-bye.